typhoid TB where we see drug resistance, otherwise it is rare. So this next rule is a offshoot of this, that if a rationally selected antibiotic fails, look for an alternate diagnosis while trying a second antibiotic. But if the second antibiotic also fails, acute bacterial infection is ruled out. Do not try a third antibiotic. Think again, where have we gone wrong? What is the diagnosis? Instead of changing the antibiotic, let's change the diagnosis. So these are the rules for fever. Now this is a revision for all of us. So how shall we analyze short duration fever? Onset is high, interfebrile normal, pattern rhythmic every 3-4 hours. On day 3, day 4 downward trend, generalized symptoms, and response is fair. What is this? Viral. Now in a viral, this history of contact is very, very important. So one question that is some family member suffering from a similar illness gives you so much confidence that this is a viral.
And if viral infection is generalized, so if there is a localization in respiratory tract, right from eyes are congested, nose is running, throat is congested, signs in the chest, maybe diarrhea, vomiting, everything. So disseminated. How disseminated? Family member, community, everybody disseminated. Bacterial infection, tonsillitis don't have chest sign nor running nose. Pneumonias have no congested throat. So localized is bacterial, generalized is viral. So many clues we do have. What is this?
High at onset, sick in interfebrile, rhythmic, day 3, day 4 worsening, localization at the site of entry, and response is poor. So what do you think? Bacterial like tonsillitis, dysentery, lymphadenitis. Okay, and then moderate to begin with, sick, rhythmic fever, worsening trend, localization by day 2, day 4 is a bacteremic process which has localized by day 2, day 4. Examples? Bacteremic which has localized by day 2, day 4. Meningitis, pneumonia. Whereas enteric is still not localized even on day 3, day 4. That's typhoid. And lastly, high fever which is erratic with spleen plus minus is malaria. Okay?
They said pneumonia and meningitis. I think acute osteomyelitis could be one.
Yeah, only thing acute. See, the issues that we are making out is that osteomyelitis, the person will come and say, my leg is paining, hand is paining, whatever. So I have an easy localization. A child of pneumonia will not localize unless he starts becoming tachypnic, which is a little later than what I could have made out. That's why we are trying to give examples of those where we miss. That is right. Just the last one.
Last thing is approach to fever as it evolves. That means on day 1, day 2, what will you do? Just rule out seriousness. If it's not a serious child, observe with paracetamol only. What will we do on day 3, day 4? We'll look for localization either clinically or by
10 minutes
or by relevant tests, and we'll consider pneumonia and meningitis on day 3, day 4, whether it's possible, UTI, etc. By day 3, day 4, if we find that it's a worsening trend, it looks like a bacterial infection, we will send relevant tests and then consider antibiotic therapy, but not on day 1, day 2. By day 5, day 7, we will assess the trend. So either with treatment of this antibiotic the child is getting better, or on his own the child is getting better, it's a self-limiting illness, and if not, then we will review and if necessary repeat tests. Day 8 to day 14 we will keep reassessing. By now usually life-threatening diseases are getting less and less common. As the days of fever advance, the chances that this is a life-threatening infection goes on reducing. So by day 8 or day 14, we have to look for additional tests and maybe think of one change in antibiotic in case first time our decision was wrong. And beyond 2 weeks, we start searching for non-infective causes. And we must remember that fever beyond 2 weeks, common causes for us, TB at any age, systemic inflammatory, that is systemic onset juvenile idiopathic arthritis, Kawasaki, and in an infant not forget neuroblastoma. Yeah, so we start this session, the post-lunch session. We come to the next symptom and that is cough, and again we'll go through the microanatomy of cough or of the respiratory system rather. So now let's start talking, all of you. Tell us what are the different anatomical parts of the respiratory system which we can correlate clinically. Excellent.
Yeah.
So one
Upper
is
airway and lower.
airway, which sir said, which is upper and lower. So airway, which is divided into upper and lower. Excellent. What else? Nasopharynx is part of the airway. Yes. What else? Excellent. So parenchyma. What else?
Accessory muscles of respiration. Pleura.
Pleura.
Yeah.
Excellent. So
And one more.
Last part. One more part. So alveoli are
Alveoli,
part
yes.
of the parenchyma.
Diaphragm.
Diaphragm is part of the the system which operates the respiratory system. Next to the alveoli is the interstitium. Excellent. So our diseases clinically can be divided. We are looking at it from a clinical perspective. So clinically our diseases can be divided into airway diseases, parenchyma, pleura and interstitium. Now let's see what symptoms.
And airway, he said upper and lower. So again we'll differentiate. And in the lower we'll further differentiate. Lower large airway and lower small airway. So each symptomatology would be different. So when we say airway disease, we will say upper or lower, and if it's lower, lower large airway, that is bronchi, and the lower small airway is bronchioles. So now we will have every symptom different to correctly pinpoint the microanatomy.
So now tell us, which symptom of the respiratory system points to airway disease? Excellent.
But cough is there in lung parenchyma, cough is there in interstitial disease.
Cough is the predominant symptom.
Predominant cough. So significant predominant cough is an airway. Fine.
Now how will you differentiate upper airway from lower airway? Cough is a predominant symptom. It could be in upper airway or it could be in lower airway. So how will you differentiate based on?
Dry cough is upper respiratory. Protective cough is mostly lower respiratory.
Okay, very good. That's
upper,
one. What
upper
else?
airway can have a metallic tone.
Excellent. So upper airway.
Lower airway cough may be productive. But
Very good. Excellent. What else?
Wheezing.
So wheezing is a sign of lower airway. What else?
stridor.
Stridor is a sign of upper airway. Excellent. What else?
Grunting is a sign.
Grunt is a sign of what? Parenchymal disease. Excellent. Very good. So coming back to upper and lower, we said stridor, we said dry, you said a different nature to the cough, metallic or barking or hoarse or whatever. So all these are upper airway. Okay. Now what about lower airway? We said we'll further divide into lower large and lower small. So any difference between the two? So I'll give you a clue. Lower large is your prototype is asthma, lower small your prototype is bronchiolitis. So what is the difference?
So we'll call lower large as bronchitis. And a lower small is bronchiolitis. What's the difference between the two? Both are airway. One is bronchitis, whatever cause. One is bronchiolitis.
Symptoms are more in bronchiolitis. Signs are less.
Very good. Excellent. So, okay, signs are less, symptoms are more. What symptom is more?
It is breathless.
Breathless. Breathlessness. Already we have said airway is cough. But breathlessness more than cough is a lower small airway. And a bronchitis, cough is more than breathlessness. Yeah. Very good. It's simple, no? So we know microanatomy. Let's see.
So we said that lower large is wet cough, all of you said, which is much more than tachypnea. Wheeze you all said, and subcostal retractions. Whereas in lower small, tachypnea more than cough, which is mild, and there may not be chest retractions. Okay. Now we come to the next, that is parenchymal. So tell us which symptom points to parenchymal disease.
Grunting.
Fever.
Okay, so
Commonly,
fever.
commonly fever.
Yeah. Then
Baby looking drowsy, signs of hypoxia, irritable.
so see, now the point that we are trying to make is, if we look at symptoms and signs, just go through your mind all respiratory symptoms and signs and think which is the most specific to indicate parenchymal disease. How we just now said that significant cough means airway disease. Grunting.
Intercostal retractions.
Excellent. So grunting and intercostal retractions are two things which could be specific to parenchymal disease. Sir?
Auscultation only. Breath sounds will be reduced.
So auscultation, breath sounds will be reduced. Now, yeah. But see, the point is very well, but point is accessory muscles are common to many. So you will have to further subdivide that where is the retraction. Accessory muscle is used even in upper airway, it is used in lower airway, it is used in parenchymal disease as well. But where is the retraction will tell us that where is the problem. So sir already said intercostal retractions. Now the question is signs. Is bronchial breathing specific to the parenchymal disease? Cyanosis, is it specific to parenchymal? You can have cyanosis in interstitial disease. So question is, how do we interpret our signs? So suppose I get a dull note, impaired note, bronchial breathing. Do I mean that it is specific to consolidation or parenchymal disease is the question. Yes, what do you think? Yes, okay.
So can the impaired note be pleural disease or a lung parenchymal disease? Both. Can bronchial breathing be seen in pleural disease?
With respect to upper lobe, there will be a signs of the upper lobe in the anteriorly, whereas in case of lower lobe posteriorly, whereas in case of pleural disease, it won't go with this anatomy of anterior, posterior or mid.
The point that Dr. Palniraman made was that signs may be very similar to many. Consolidation, collapse, cavity, pleural effusion, many things are common to all. There will be a bronchial breathing in all. There could be an impaired note in all. So it will not differentiate easily, though mostly yes, mostly no. But what differentiates definitely is the distribution of signs. Lung parenchymal signs are distributed through what is referred to as a lobar distribution. That means one lobe is involved, other lobes are not involved. So where is the upper lobe anatomically? Only anteriorly upper half. Where is the middle lobe? Anteriorly lower half. Where is the posterior lobe? Lower lobe only posteriorly. So if the signs are only posterior and nothing anterior, it is lower lobe, so lung parenchyma. What about pleura? Pleura is covering all over. So the signs will be all over, anteriorly, laterally, posteriorly. That's a major difference. So we said that lung parenchyma signs are localized, pleural signs are localized, but two can be differentiated by distribution. What about airway signs? Airway signs are generally generalized. Exceptions are there. Which is airway disease which has a localized signs?
Foreign body bronchitis.
Foreign body. Inhaled foreign body is an airway disease with localization. Okay, but what is localization? Lung parenchyma, collapse or emphysema. So again, it's a lung parenchyma disease. Okay, so I think this is what we want to talk about. That's there. So lobar distribution, we are all clear? Yeah. So now it's all at MD level, bronchial breathing, crepitation, yes, no. Who wants to know? Localization, yes, no. If generalization, airway, localization, pleura or lung parenchyma. Difference between the two, distribution. Forget what signs are there. For example, cavity. Cavity can have no signs or every sign. It does not matter. So I think these are very, very simple way of that. But look at that, cough not predominant. Cough is not a predominant symptom. Okay, and therefore, that's, what about pleura? We have already said what about pleura. Any specific symptom of pleural disease? Pain, right? So, fine.
So in pleura, pain, tachypnea, that means could be breathless, but no retractions. So we said retractions of intercostal type in parenchyma, subcostal in lower airway, suprasternal in upper airway. But in pleura, no retractions. And again, localized signs and pleural distribution. That means anterior, axilla, posterior, everywhere. So what sir made a point that even if we are not so confident of what sign we are picking up, what type of bronchial breathing or what type of crepitations, fine coarse, whether they are all over or whether they are localized makes a big difference. And if they are localized, whether they are performing to one lobe anatomy or not makes a big difference.
Again, look at that. No chest retraction in bronchiolitis, lower small airway, and no chest retraction in pleura. Okay, one is localized, another is generalized. So easy. Take up any sign, you can differentiate everything. Take multiple signs, you are very sure what it is. What about interstitium? What is the symptom of an interstitial lung disease?
How do interstitial present?
Tachypnea or shortness of breath?
Breathlessness,
Shortness of
tachypnea, very good. So cough is mild, tachypnea and generalized signs. Okay?
So now look at that. Even lower large, okay, that's easy, lower small. But lower small and interstitium look alike. Both have tachypnea more than cough, right? So then how do you differentiate the two? You got both similar almost?
Duration, sir.
Duration
of
may be
illness.
one. Many interstitial diseases are chronic, but there is an acute interstitial pneumonia as well. Yes?
Age group. Age group.
Okay.
Age group.
So I think the major difference is again that in acute bronchiolitis, he made a point that you will have no localizing sign, but you may have an emphysema. Okay, whereas an interstitial lung disease, you will not have emphysema, but you may have in fact fine crepitation. Small difference. Forget interstitium for a while, it's not common, but we just want to be sure anatomically how we can differentiate each one of them, right? Yeah.
And therefore we talk of combinations. So when you have generalized, we said earlier while discussing fever that viral infections are generalized. That means right from the nose to the throat to the chest. So you have generalized signs of airway plus lung plus interstitium, it's likely to be a viral infection. We have localized signs, it's pleuroparenchymal, it's likely to be a bacterial infection.
I think most of the time this will hold true. Okay. There would be small exception which may be not very uncommon. Therefore, we would like to make a mention of it. We said localized is pleurocarditis. What does that mean? Bacterial infection is of a lung parenchyma, not an airway. Okay. Whereas if airway and lung parenchyma, everything is involved, is viral. Exception, the intracellular organism, like a mycoplasma pneumonia. Mycoplasma affects the airway as well as the pneumonia. So that's called an atypical pneumonia, etc. So mycoplasma is one example where a bacterial infection looks like viral. There what the fever, etc. will make a difference. So everything we take together, we would be able to even pick up a mycoplasma bacterial infection by clinical judgment. Yeah.
So let's look at the cough rules. Now the first rule is clarify the terms. Now we are all familiar with patients saying that he has got cough. Now when you say what do you mean by cough, patient says he vomits out cough. So then you ask, is he vomiting or is he coughing? So he says no, he has got cough. So you don't know what is happening. So clarify what they mean by cold, cough, etc. So whether there is something coming out from the nose, whether it's a discharge, whether it's a rattling of the chest, whether it's actually frequent coughing.
I think every symptom we want to anatomically localize. So if there is a cold, you need to ask the parent, what is cold? Running nose? They would say no. Then blocked nose? No. Then what is cold? No, noisy breathing. That means they take us away from that symptom totally. But if there was really cold, that means the nose was running, TB is out. There is no tuberculous rhinitis. Okay, so if somebody is running nose, man-to chest X-ray is out. But they all in one breath only say, sir, fever, cold, cough for a long time. So it's, oh, TB. But is there a real cold, real cough? An infant has a noisy breathing, they will come and say lot of cough. Lot of cough in the chest. He say, no, not that. Only noisy breathing. No, noisy breathing may be a laryngomalacia also. What X-ray and what antibiotic. So that's the point we are making. Time and again, no cold, no cough presents as cold and cough. And then for us cold and cough, so chronic, recurrent, we put all kinds of differential diagnosis. So make that clear. That's the point, right?
Then we said cough as a predominant symptom, we said was airway. So we divide this into two broad groups. Without fever, by and large, it's hyperreactive or asthma. With fever is acute viral infection or Walry, and both often have also a cold.
So I think the point is it's so simple. If somebody has a cough as a predominant symptom, with fever, viral infection. And without fever, hyperreactive airway. Both do not need X-ray chest. Because both are out of, don't need CBC. Just by that story. Okay. Further.
Now, the other issue is mostly predominant cough is not an acute bacterial infection, because we said predominant cough is airway and airway is viral. So
Give an example of a bacterial infection, respiratory tract, with a predominant cough. That is an exception. Rule is
whooping cough.
Whooping cough, simple. Okay, so barring pertussis, one who has a high fever and cough badly is not bacterial. So no antibiotic. Okay.
Okay, so more the cough, lesser the need for antibiotic and chest X-ray. In practice, it's often reverse. Okay, but this is now, let us think for a minute, and what is wrong in this? This is very scientific and very clear. More the cough, less the need for antibiotic and chest X-ray. But we've not waited to think about this.
And if you read Nelson, the differential diagnosis radiologically of pneumonia is asthma. I was wondering what is common in both. One has high fever, another has no fever. One has recurrent, another is not recurrent. Name everything is different. Why? Because any shadow in the lung, the radiologist will call it pneumonia. If it is small shadow, he call it pneumonitis. If he is not sure, he will say query pneumonitis. Now, we should not ask for an X-ray if he is coughing badly. Exceptions, inhaled foreign body, or maybe a mycoplasma or chlamydia pneumonia, but not usual. So, more you cough, no X-ray, and more you cough, no antibiotic. From tomorrow, no antibiotic for a cougher. Okay, exceptions are there. We can make out exception after a few days. Why give antibiotic to all, or why give chest X-ray to all? And there is nothing like pneumonitis. Pneumonia is an inflammation of lung parenchyma, and pneumonitis is an inflammation of pneumonia. What nonsense. So, I think there is nothing. Pneumonitis means I don't know what it is. Okay. Yeah. So, don't take those things out. Every cough patient has a chest X-ray which is abnormal, which only tells you that he is coughing. That's it. That he is telling you also. Why do you need an X-ray? Yeah.
And the further problem will be that in more the cough, the X-ray may come normal also.
Yeah.
And then he will blame you, itna khasi hai, phir bhi you are saying X-ray is normal.
And generally who has a cough for a long time has multiple X-rays. Yeah, he comes with 4 or 5 X-rays. Sir, no X-ray is showing anything, but his cough is there. X-ray does not show airway. So if it's an airway disease, no chest X-ray.
No. This is one situation where a bacterial infection like an adenoid or a rhinosinusitis, one of the gentlemen, sir, was making a point at lunch. These are the conditions where there will be cough and there will
But
be
there will be a dry cough. It's an upper airway. Lower airway bacterial infections are rare with acute onset. TB is different. TB is a subacute or chronic. We are talking about an acute illness and an acute problem.
And this we have discussed. Acute onset cough worsening over a week is pertussis. Inquire history of contact. Now this is a simple but a practical flow chart for approach to recurrent or persistent cough. So again, this is so common in practice that last 1 year many episodes of cough or continuously having recurrent illnesses. So we divide them into two groups. Is the fever significant? That the cough is significant is already obvious from the
And I
history.
think the point here is that recurrent and persistent are not easy to differentiate. Okay, the classical difference would be in a recurrent cough, you have a larger period cough free. But for example, every asthmatic fellow is coughing through the night and is all right through the day. Will it be a recurrent or a persistent? So, I think by and large the difference is not difficult to make out, but both mean the same thing in terms of analysis. So, for practical purposes, this analysis is good for either of the two.
So we'll decide whether there is significant fever or no. If there is significant fever, that means this is an infection. Next you have to decide, is it viral or is it bacterial?
Yeah, now we are all very, very expert in that. We have done viral versus bacterial, so we know clearly, yes, there is no difficulty. So, with fever, viral or bacterial. If viral, forget about it, reassurance.
And if it is bacterial, then we need to decide, it will be localized. So we have to decide where is the localization. Is it upper respiratory bacterial or lower respiratory bacterial? If it is upper respiratory, look for these underlying abnormalities. Adenoid, tonsillitis, sinusitis. If it is lower respiratory, recurrent, bacterial, lower respiratory infections, that means there is again some major underlying abnormality like a cystic fibrosis or an immune deficiency or a ciliary defect or a TB. So these are both the groups, means the message is that recurrent bacterial infections have to have an underlying cause, have to have a reason why there is recurrent bacterial infection. So we need to investigate, and this group where there is recurrent lower respiratory infection, their health will also deteriorate.
So I think the message is that if you write an antibiotic second time within a short period for the same kind of illness and you are convinced it's bacterial, then you will have to find the underlying cause. So you can't go on giving every month an antibiotic to a febrile child with cough. Either you are unnecessarily giving an antibiotic because it's viral, or if it's genuine, then a second episode of similar disease coming again should start worrying you. Why is the recurrent? What's the message? Bacterial infections do not recur unless there is a background cause. Viral infections recur even without any cause. So recurrent bacterial. So don't write second time an antibiotic for the similar illness in a short time. Well, if you got bacterial infection twice in a year, that's okay, but not quickly again and again. And I think that is important. So if you write second time an antibiotic, you should really consider you're missing something. You keep a watch. If you don't find, treat it. Third time he comes, there has to be a definite cause. And I think that's what it is, right? So this is about fever and cough. Again, don't forget, cough is the predominant symptom. So we are discussing cough just now.
And then if this group of predominant cough, recurrent, persistent, has either no fever or occasional fever, then you look for history of episodicity, nocturnal, which tells you this is hyperreactive airway disease, and then you decide whether it's atopic or non-atopic. By atopic, we mean history of allergy, either personal or family, and that will lead us to asthma. And in non-atopic, this baby could have aspiration, could have been premature with some lung interventions at birth, or could be foreign body.
I think here the issue is that this group may also have an occasional fever. Parents might say, oh, my child is getting episodes of cough for last 1 year off and on. Your next question is, cough is predominant. Next question is, what about fever? Oh yes, there is fever also. How high fever? Does fever come every time? When you ask in details, this child will say on the right hand side that no, not every time there is fever, but only sometime there is fever, which means it's not primary infection. Infection comes every time with fever. Then why do they feel warm? For varieties of reasons. It's after all an allergic inflammation. So there could be a little felt feeling of warmness, but never a high fever. Occasionally it could be a viral infection induced hyperreactive airway. So I think asking questions that every time fever or no, mostly they would say no, not every time. Out of 10 times, how many times? Maybe 2-3 times fever, but 7-8 times no fever. It's a hyperreactive airway. So I think that's why we have put occasional fever, right? Yeah.